All right, let's get right into it. Today, we are tackling some of the scariest, highest-risk respiratory situations you'll ever see as a nurse. These are the safety rules you have to know, not just for the NCLEX, but to literally keep your patients breathing. So, let's do this.
First, we'll cover the absolute #1 rule of patient care. Then, we'll dive into a really dangerous trap with COPD patients. After that, we're on to protecting artificial airways, handling chest tube disasters, and getting oxygen therapy right. And of course, we'll wrap it all up with a quick recap of the biggest takeaways.
Okay, so before we jump into any fancy emergencies or anything, we have got to nail down the one fundamental rule that comes before everything else we do in nursing.
And it's this right here: airway, breathing, and circulation. The good old ABCs. Every single patient assessment, every intervention, every time, you have to make sure these three things are good to go. A problem with any one of them is an immediate, life-threatening emergency. This is the bedrock of patient safety, period.
So when we talk about protecting the ABCs, what does that actually look like for the respiratory system? Well, it means we're protecting these three pillars. You've got ventilation, that's the mechanics of breathing, like a bellows. Then there's perfusion, that's the heart pumping that oxygenated blood around. And finally, diffusion, that's the magic happening where the oxygen and CO2 actually swap places. If any one of these breaks down, if air can't get in or blood can't move or the gases can't trade, your patient is in big trouble. Our whole job is to keep this system working smoothly.
All right, let's talk about our first big clinical trap. And trust me, this is a huge favorite on exams because it feels so backward. We're about to find out why giving something that seems so obviously life-saving, oxygen, can actually kill a certain type of patient.
Okay, check this out. It's like a complete rewiring of the brain's control panel. In you and me, our brain's main trigger to take a breath is when it senses CO2 levels getting too high. It's like a built-in alarm saying, hey, get this waste product out. But for someone with severe COPD, their body is swimming in high CO2 all the time. So the brain just gives up. It starts ignoring that alarm completely. Now the only thing left that tells their brain to take a breath is a low level of oxygen. In that new rewired system, it has a name: hypoxic drive. Their whole motivation to breathe now comes from having low oxygen. So you can see the problem, right? What happens when we see their O2 sats are a little low and we do what we think is right? We blast them with a ton of oxygen? Well, we just took away their one and only reason to breathe. The brain goes, oh, plenty of oxygen, I guess we're good, and the patient just stops breathing.
So how in the world do we give these patients oxygen without knocking out their drive to breathe? The answer is the Venturi mask. Think of this thing like a sniper rifle for oxygen. It's not a shotgun blast. It delivers an exact, super precise, low dose. This lets us bump up their oxygen levels just enough to be safe, but not so high that we switch off their hypoxic drive. It is absolutely the go-to tool for this job.
Let's shift gears to another really high-stakes situation, taking care of a patient with an artificial airway, like an ET tube or a trach. Our main job here is to protect them from a really nasty complication called ventilator-associated pneumonia, or VAP.
And it all starts with this number range, 20 to 30. This is the Goldilocks pressure for that little inflatable cuff on the end of the tube. It can't be too low, and it can't be too high. It has to be just right. And here's why that's so important.
See, if the pressure is too low, you don't have a good seal, and that allows all this bacteria-filled gunk from the mouth to just trickle down past the cuff and right into the lungs, causing a terrible pneumonia. But if the pressure is too high, that cuff basically acts like a tourniquet inside their throat. It crushes the delicate blood vessels in the tracheal wall, cuts off blood flow, and the tissue can actually die. Both are total disasters. So to fight against VAP, we use something called the VAP bundle. And this is so smart. These aren't just good ideas. They're a proven set of actions that when you do them all together, they save lives. It's simple stuff, really. We keep the head of the bed up to let gravity help us. We do regular oral care to kill off the germs. We suction out any secretions that pool up above the cuff. And we're always asking, can we get this tube out yet?
All right, time for a little scenario. You're in the room alone with your patient, and you have to change the ties that hold their trach tube in place. There is one golden rule here, one thing you can absolutely never, ever do wrong. What do you think it is?
And here it is. You always secure the new ties before you take the old ones off. Always. Because all it takes is one big cough from the patient, and that unsecured trach tube can literally fly right out of their throat. And boom, you've just had a catastrophic airway loss. This one simple rule prevents that entire nightmare. Okay, now we're ramping it up. We're talking about the most urgent, time-is-everything emergencies you can have with a chest tube system. When this thing fails, you have seconds, literally seconds, to do the right thing. Now listen up, because there are two main disasters, and you cannot mix up what you do for them. If the tube just disconnects from the collection box, your first priority is to create a new water seal. You grab that tube and stick the end into a bottle of sterile water. But if the tube gets pulled completely out of the person's chest, you now have a gaping hole. Your first priority is to seal that hole. Slap your gloved hand over it immediately, then get a proper dressing on it. Two different problems, two totally different solutions.
So, how do you know what's going on? You look at the water seal chamber. It's like your window into the patient's chest. If you see tidling, that's the water level gently rising and falling as they breathe, that's good. That's normal. It just means the lung isn't all the way back up yet. If that tidling stops, the first thing you do is check for a kink in the tubing. But continuous bubbling, that is a big, flashing red light. That means you have an air leak somewhere and your job is to become a detective and find it fast.
Let's switch gears and talk about something we use all day, every day, oxygen. It's so common that it's easy to get complacent, but we have to remember to treat oxygen like any other powerful medication, because that's exactly what it is.
Each of these common devices has a critical safety rule. With a nasal cannula, if you're running it at 4 liters per minute or higher, you've got to add humidification so you don't dry out their nose and throat. For a simple face mask, you have to run it at least 6 liters per minute. Otherwise, they're just rebreathing their own CO2 inside the mask. And for a non-rebreather, you gotta watch that reservoir bag. It needs to stay partially inflated when they breathe in. If it's collapsing all the way, they're not getting enough oxygen.
And we can never, ever forget that oxygen is fuel for fire. It's highly combustible. It won't start a fire on its own, but it will make any tiny spark into a massive inferno. So the home safety rules are absolutely non-negotiable. Keep it far away from heat, put up no smoking signs, and yes, that includes vaping. And a big one, never use any petroleum-based products like Vaseline on or around the equipment. They can actually ignite in an oxygen-rich environment.
Wow, okay, that was a lot of critical info. So let's boil it all down. Let's do a super fast review of the absolute most important things you need to walk away with today. Remember this forever. Your patient's brain is the first thing to freak out when it's not getting enough oxygen. So the very first sign you'll see is a change in their mental status. They'll get restless, anxious, maybe confused. A patient turning blue, cyanosis, that's a super late sign. If you're waiting for them to turn blue, you've already missed your chance to intervene early.
When you're suctioning someone's airway, remember you're also sucking out their oxygen, so you have to be quick. The rule is simple: no more than 15 seconds of suction at a time. And you only apply the suction while you're pulling the catheter out, never on the way in. This is how you prevent causing trauma and stealing all their oxygen.
So let's end on this final question to bring it all home. You have a patient who just came back from surgery, and all of a sudden they're getting really restless and anxious. Based on everything we just talked about, what's your brain screaming? What are the first 3 things you're going to check? Think ABCs, think early signs of hypoxia. Answering that question, that's how you save a life.